Hey everyone, welcome to session 99 of the Behavioral Observations podcast. Wow, 99 episodes. Can't believe we're almost at 100. I do want to let you know that the next episode will actually be 101. You see, I'm going to bend the time-space continuum. Joking aside, what I mean by that is that I have a special episode planned for you for episode 100, but I can't record it for a couple of weeks, so we're going to just play around here with the math and go from 99 to 101 to 102, and then we'll come back to a special episode for episode 100, and we'll probably air it sometime in the month of December. So the details I kind of want to hold close to the vest for the time being, but take my word for it, it should be pretty fun. And speaking of fun, I had a really fun time speaking with Dr. David Cox in this session of the podcast. We chatted a bit about the importance of the experimental analysis of behavior, the basic concepts that underpin behavioral economics and behavioral pharmacology, and some of the research that he's conducting at Johns Hopkins. Later on in the podcast, we also delve into the developing research in the use of psilocybin mushrooms in the treatment of smoking cessation and other behavioral and mental health challenges. There's a lot of exciting work in this area, and I'm glad that behavior analysts have a seat at the table to try to figure out why these interventions are so effective. Towards the end of the interview, we take a lot of listener questions about a variety of topics, including psychotropic medications for clients, as well as CBD oil and a whole host of other things. Now, let me be clear. When we talk about mushrooms, more so speaking for myself, during the show, we kind of joke around a little bit about it here and there. I want to make a couple of quick points. All joking aside, this is serious business, and the people seeking treatment are trying to address serious problems. And so this episode should be considered for informational use only and not be considered any type of behavioral health or mental health or medical advice. In other words, if you want to stop smoking, you have PTSD or anything else, please seek treatment from a qualified care provider. Don't run out and take a bunch of mushrooms. These studies have been conducted, again, with the utmost medical supervision, and really the protocols are still being developed. So I just want to put that out there. Another thing I want to mention is that there are tons of information in today's show notes. So you're going to want to head over to behavioralobservations.com and just look for David's name. Better yet, sign up for my email list because I send the show notes to each episode out to all of my subscribers. Before we get to the show, I want to let you know that we are brought to you by the University of Cincinnati's online behavior analysis program. Gain the cutting-edge knowledge and skills so you can help others while increasing your career options with UC Online. For more info, go to behavioranalysisuc.online. We're also brought to you by the OVM 2.0 workshop that's being hosted by my friends at Connections Behavior Planning and Intervention. It's being held on January 18th and 19th in 2020 at Green River Community College in Auburn, Washington. For more information, visit connections-behavior.com/events. Lastly, I'd like to mention something I don't bring up all that frequently. I have a membership program for the podcast. Think of it as a do-it-yourself Patreon. It's been running for a few years now, and it's $9 a month. Members get access to a private Facebook group in which they are able to get nearly instantaneous access to the videos of these podcast interviews. This interview, for instance, has been available since October 22nd. The best part is that members get the raw feed. That means no ads and none of these introductory comments. You also sometimes will see some bloopers where we redo some questions. You just get the raw interview itself. Another cool thing is that we do hold occasional Zoom hangouts with former guests. We do this about 6 times a year, and it works like this. We schedule a Zoom call with a guest, and then the members join us, and then the members have the opportunity to ask questions to the guest directly. The last episode with Pat Fryman is a good example of how this works. And coming up on November 13th, I'll be hosting Dr. Luis Morales-Knight, who joined us a few months ago to talk about parenting, working with adolescents in a mental health setting, and so forth. Luis is great. He's a lot of fun, and I think this will be a fun hangout, so I hope you're able to join us. So, having said all that, I think that's it for opening comments. So let's get right to this fun conversation with Dr. David Cox.
Welcome to the Behavioral Observations Podcast, stimulating talk for today's behavior analysts. Now here's your host, Matt Sikoria.
Dr. David Cox, thanks for coming on the Behavioral Observations Podcast. How are you doing today?
I'm doing well, Matt. It's nice to be here, and I really appreciate you inviting me on.
Oh, yeah. I appreciate you coming on the show. We've got a lot of fun stuff to talk about today. And I think you and I have been kind of connecting on Twitter for, I don't know, the last year or two, and it's fun to actually have the conversation, at least at this point virtually, but at least we could see each other now and it's not through text. So thanks for taking
a face to the name.
Exactly. Thanks for taking time out of your morning to chat with me. Like I said, we've got a lot of fun things to talk about. And one of the topics that's kind of near and dear to my heart is the experimental analysis of behavior. Not that I'm, claim any kind of expertise in it, and I don't really keep up with the literature all that much, but at least it has a sentimental place in my heart, given that that's kind of the way I found myself into this field of behavior analysis. And so I'm looking forward to kind of digging into that, and also digging into the aspect of EAB that kind of spans, behavioral pharmacology, drugs and behavior, and things along those lines. So I'm really happy that you're here. But before we kind of get into that stuff, I want to hear about how you found your way into behavior analysis. So if you can kind of walk us through how you discovered the field, and then kind of take us up to what you're doing these days, that would be a great place to start.
Yeah, sure. So I guess how I got into behavior analysis and then kind of chose it as my career were two kind of confluences of variables that kind of met at two different points. Originally, my first contact with applied behavior analysis was during my undergraduate at Arizona State University. And I was a pre-med psychology major, also working about 30 hours a week in retail. And everyone who knows the grad school game knows that you have to have some kind of resume or a CV experience to help you get into that clinical domain or whatever your program is. And because I was interested in psychiatry, in the summer of 2006, I was working at a UPS store. Packaging boxes, trying to get people to pay more for UPS rates than USPS. And it's, 118 degrees outside, summer afternoon, Tempe, Arizona. And I'm on the job scrolling through the internet looking for jobs, as most undergrads probably do. And I see this job posting for an autism habilitator. And most jobs, I guess, in clinical realms, you have to have a bachelor's or a master's or something. So here's a degree, doesn't require bachelor's. It's kind of within that mental health realm. No idea what it was, but I was like, I'll give it a shot. So applied, got the job, started in late August, maybe early fall of 2006 on that job. And simultaneously, I started taking two courses in my undergrad. One was sensation and perception and learning and motivation. And ironically, both were taught by cognitive psychologists, which is kind of funny in retrospect.
Yeah. It's funny how common that is, I think. I remember the old S&P course from the University of New Hampshire. So, yeah.
Yeah, it's interesting. And, I'm not sure what faculty lines looked like back then or even today for behavior analysts. But, yeah, I'm sure there are a lot of people that are filling gaps here and there and teaching the material. So I'm taking these classes, absolutely loving it. In retrospect, learning and motivation was essentially behavior analysis 101. And then sensation and perception was how physical events in the environment kind of impact biological systems. So I have that going, plus the learning and motivation, so how these stimuli can change behavior over time. Learning that stuff during the day, and then afternoon, evenings, and weekends, applying it to individuals with autism spectrum disorders and developmental disabilities to their programs. And it just kind of all clicked. It all just made sense, I think, because I was doing both aspects to it. Or the learning the basic stuff in school and then applying it in the field the same day. And really kind of that in and of itself has really impacted my career, I think, to this point. Because right from the beginning, from day one, it was studying kind of these basic biobehavioral processes and then trying to translate it into the applied realm. And I've been fortunate enough to keep doing that kind of line of work throughout my career. So that's kind of how I was exposed to
Sure.
behavior analysis.
And so
applied
what made
to-
you like, oh, I want to do this for grad school and I want to do this for, a living, and how'd you land up, how'd you end up landing at Johns Hopkins? So.
How did I get hooked by the field?
Yeah, exactly. Yeah.
Yeah. So I was pre-med, didn't get into med school when I graduated. So I moved back to Colorado to work. I worked at an interdisciplinary clinic for children with autism spectrum disorders and developmental disabilities. So we had SLPs, OTs, licensed psychologists, and special education teachers that were writing some of the skill acquisition goals. And then behavior analyst was managing the reinforcement systems and then also helping with behavior reduction goals. And then direct staff, which is me, we were implementing all this stuff. So I'm kind of doing that, and I wanted to, again, play that CV game to try to reapply to med school. So I found this program in bioethics that kind of hit this nice interaction between biology, medicine, healthcare, and seemed like it'd be good for the CV to get into med school. And I was about a year into that program, so it's like fall of 2010, and I was starting to get a little dissatisfied with the approach to clinical ethics. So I kind of entered this degree program. I'll rephrase it. What's nice about applied ethics is you have to make a decision. So they're like big philosophical questions that thinkers will take dozens of years, hundreds of years to answer. But in clinical ethics or medical ethics, you have to make a decision now. Mm-hmm. So that was appealing. So I thought these guys are going to have answers. They're going to tell me how to make these decisions. About a year into the program, I was a little dissatisfied. It wasn't as objective and measurable as I thought it would be. And at the same time in that fall of 2010, a little bit dissatisfied with the program, a colleague at the clinic I'm working at, Megan Deshay, who's up at Caldwell University now, she was taking her BCBA coursework. And so we start talking about the science of behavior analysis, kind of above and beyond what it is that we were doing at the clinic. And then I was also restudying to take the MCAT, and I loved the physics aspect of it. And I was simultaneously thinking man, I wonder if there's some analogies to these physical laws that work with human behavior that seem so cool. And I'm explaining this to a BCBA that's helping us out. And all super casual, he goes, oh, you mean behavioral momentum? I was like, wait, what? This is a thing. I didn't even know what job and JAB was. So he pointed me to Nevin's 83 article. And so I was hooked with quantitative analyses, seemed to offer a very precise way to think about measuring environment behavior relations. I was exposed to kind of the science as a broad aspect from Megan and just all the things that it can account for. And I thought wow, maybe this is the realm that I can use to come up with more objective and measurable approaches to ethics. And now I also learned that being a behavior analyst is something you could get paid to do. So I was like, oh man, I get paid to think about this all day. This is amazing. And that's really what kind of hooked me, that confluence of variables in that one semester. So I was hooked. So then after that, I went to, I got the University of North Texas graduate certificate in applied behavior analysis, got my BCBA, moved to California and worked out there in kind of a standard program supervisor role as a BCBA for a few years. When I was there, I found I really liked the kind of difficult to treat clients. Those were kind of the caseload I started gathering. So older children, adolescents, and adults, either severe behavior or they were really hard to find reinforcers for. You might find some stimulus that works as a reinforcer for a session or two, and then you're beating your head against the wall again. Or I guess another type of client was individuals that had automatically maintained behavior that it was really difficult to control access to the reinforcer or to compete with it.
Sure.
And that also kind of got me in that behavioral economics choice frame, started to think, how can we actually quantify the reinforcer value for this automatically maintained behavior so I can compete with it? Started looking around the literature, and that's where I found substance abuse. And I was like, oh, these people have been thinking about this for decades. I'm sure they have some answers. And so that led me to Jesse Dallery at the University of Florida. He also does a lot of stuff with quantitative analyses of behavior. So it was kind of a perfect match. Went down there, obtained my PhD, primarily doing human operant work with choice behavior, discounting, matching, verbal behavior. And then the last year that I was down there, the postdoc opportunity at Johns Hopkins opened up. And I had been writing a lot about substance abuse in my introduction and discussion sections. Like, this is how all this basic research applies, but I didn't have as much direct experience with it. And so when that job opportunity opened up, I applied and, came here July of 2018. It's about 15 months or so ago.
Okay. So what is your kind of day-to-day job right now?
Oh, yeah. Good question. So my day-to-day job, we have one grant primarily that we're running, focused on it's behavioral economic demand analyses with two different types of cigarettes. And I can't talk much about it because the cigarettes themselves, because it's blinded.
Okay.
And the research assistants may listen, and they're not supposed to know.
Okay.
But yeah, so we're using demand analyses to essentially see if the different cigarettes influence patterns of consumption, which is pretty cool, and it could have some policy implications and things like that.
Okay.
So it's one study we're playing around with, and then the rest of my time, I'm playing around with large data sets, quantitative analyses, and using machine learning to try to figure out. Essentially playing around with like discounting data sets, choice behavior, trying to see if we can make some connections, and then also there's a lot of data on individuals that have come through Hopkins that have received psychedelic-assisted therapy, and we really don't know how it works. And so I'm trying to use machine learning to take patterns of drug use history and kind of demographic information to see if we can predict who it's even going to be successful for, who it's not, things like that.
Awesome. So much to get into there.
A lot of fun stuff.
This is great stuff. Let's level the playing field, though. There's going to be some audience members who don't have a background in and perhaps some of the terms, or they might have heard them in a survey course, but have kind of they might have decayed in storage a little bit, to use a cognitive psych term, I guess. And so let's take a quick detour or a quick lap around the EAB track here, and before doing that, again, this kind of harkens back to some of the conversations we had through email or Twitter. I can't remember which, but you've made the case for studying EAB, and so. Tell me a little bit about why people should become a little bit more interested in that, or even if they're not interested in that, what sort of things they should pay attention to, what are some of the key findings. And then what I'd also like to do is, we're throwing around terms like discounting and things like that. And as much as I'd love to think that everyone, has listened to session 17 with Derek Reed, or earlier with Aaron Rasmussen, or even earlier with my another buddy of mine from Auburn, Steve Lawyer, where we talk about all those things. Those are pretty far back in the behavioral observations archives, so we might want to level the playing field a little bit and just kind of do some quick definitions here. But let's start with making the case for learning or refreshing our knowledge of the experimental analysis of behavior. Yeah.
So I think understanding what's going on in the experimental analysis of behavior is important, because that area of our science really is aimed at figuring out how and why some of these things are working the way that they are, so we can then ideally translate that into an applied domain to improve interventions that we might have, or to troubleshoot some of those standard operating procedures that might not be working as well. And so having a nice background in EAB and understanding kind of the basic behavioral processes of stimulant behavior environment relations, I think can help troubleshoot those programs.
Okay. And so what are there some essential concepts that would be helpful for practitioners to use as a lens for examining these things?
Yeah, I think so. I think if people are really interested in kind of what their basic brothers and sisters out there are doing, there are 4, maybe 5 domains that would probably be important. The first is matching. So especially since the 1970s or so, the choice behavior generally, I think, dominates a lot of the interpretations of experimental analysis of behavior. And by choice, I just mean concurrent schedule. So the organism has 2 or more schedules of reinforcement that they can respond on at any moment in time. And so a lot of that choice research has been trying to figure out how can we change dimensions of the reinforcement schedules, the qualities or characteristics of the reinforcers, and things like that to then predict and kind of push around behavior to one response alternative or the other. And matching really is a very classic example of that. So matching is great. And I think if people were going to read 2 articles to catch up, I suppose, Baum's 1974 on 2 types of deviations from matching law and JAB is a good one. And then Jack McDowell has a 2005 paper on the classic and modern theories of matching, which is also in JAB. And I think if people can get through those, they'll be well caught up.
Deciding to take the next step in your career is a big decision. Whether it's moving from a registered behavioral technician to a board-certified behavior analyst, or learning how to apply behavior analysis within a school setting, the University of Cincinnati online behavior analysis program can be a rewarding way to advance your career. Gain cutting-edge marketability, knowledge, and skills to increase your earning potential, all while improving the quality of life for others. The University of Cincinnati, a premier research and higher learning institution, ranks in the top tier of America's best colleges by U.S. News & World Report, and it's fully accredited through the Higher Learning Commission. So if this sounds interesting to you, please visit behavioranalysisuc.online for more information. You said
in that domain.
McDowell, did you say 2005?
Yeah, 2005.
All right, cool. And I'll have links to these in the show notes, as with as many other notes I can make here as we chat. So
nice.
All right, nice. So we got matching. So
matching. The other one, discounting. I mean, that's a huge topic right now. It's absolutely blowing up. I give talks on kind of how the basic processes inform ethical decisions that people make. And I always trot out discounting, like how it's relevant. And each time I update the Google Scholar hit searches for those terms, delay discounting and probability discounting and temporal discounting. And it's up over like 200,000 articles or something crazy now. So it's a huge area of the literature. And at a very basic level, discounting discounting focuses on reinforcer value, which essentially just means how much behavior you can get for a reinforcer. So maybe if I want to know how much you value like one apple, let's say I could make access to an apple contingent on math worksheets, and then I can increase or decrease the number of math worksheets required to access the apple until eventually I figure out it'll work. I don't know, you complete like 5 worksheets for an apple or something. Now, so then I kind of have the value of one apple related to worksheets.
So if you go to like 6 or 7 or 8, then the worksheet completion behavior will extinguish, basically.
Yeah, too much. Yeah, exactly. And in discounting research, if I'm really interested in understanding reinforcer value more broadly, apples aren't very helpful because like some people love apples, other people hate apples. So a lot of times research will use money because a lot of people have familiarity with money. They've worked to gain access to money in the form of jobs and paychecks. And if you stop paying money, people stop working. So it's safe to assume it's a reinforcer. And so discounting as a field or as an area of study very broadly is focused on how can I change some characteristic of that reinforcer to reduce the amount of behavior I can get from you. And so the two most common ones that a lot of people are familiar with are delay discounting and probability discounting. So for delay discounting, essentially by delaying the time from when I complete a response to when I actually contact the reinforcer, that reduces the value of it or the amount of behavior I can get you to emit to contact it. And then for probability discounting, it's the same basic idea. If I reduce the probability or the likelihood that you'll actually contact a reinforcer after a response, the amount of behavior I'm going to get from you reduces. So reinforcer value reduces. And there are a few articles that I think would be really helpful if people are interested in learning more about that. One, Amy Odom has a great article in 2011 in JAB as well called Delay Discounting. I'm a K, you're a K. which is great and kind of is a nice reference to this notion that the way that delay impacts reinforcer value varies from individual to individual. So that's what that I'm a K, you're a K is. Each of our rates of discounting are going to differ slightly. Mm-hmm. And then another article would be Todd McKercher and Renee Renda, 2012. In the Psychological Record, they have a review of delay and probability discounting. And that's nice because it brings in the probability discounting component. But both of those articles, I think, do a really nice job of highlighting why researchers are interested in discounting, how it's studied, and the relationship in particular between discounting and health behaviors, which I think is the main reason, at least in behavior analysis, why it has drawn so much attention. So.
Very cool. All right, that was super concise. So we got some basic terms outlined, and we got some
nice.
Articles that people can follow up on. And again, I'll run those links down and have those on today's show notes. So very cool. So let's talk about. Well, actually, let me just back up a second. So you mentioned that's the cigarette study, right? So basically, if I'm gonna let me guess about how this might work here. So, is it something where someone has to, engage in some behavior? And of course, I'm thinking like lever pressing or something like that. But it could be some. Obviously, these are humans, so there might be mouse clicking or whatever until they get like a puff. And then you're going to progressively increase the number of clicks per puff, and then compare cigarette A and cigarette B. Is that the basic design?
Yeah, that's perfect. And this is kind of the area of demand, which I think is another really cool area of EAB if people are interested in it. But people are they sit in a room and they have this box with 3 levers that they can push or pull, or plungers, I think they're called. Lindsley plungers, I think is the technical term. But yeah, they push any either one press or pull, 10, 100,000, or 10,000, I believe, are the ones we're running. And at the end of that, they can earn a puff, or I think it might be a few, on a cigarette of interest. And we have it attached to this cool device. So as they smoke it, we can get in all this information on how much they're inhaling and all the dimensions of the cigarette puff, which is pretty cool.
That's neat. And so theoretically, one cigarette someone might want to emit more behavior to get one cigarette over the other, and that's the experimental question.
Yep, based on the dimensions of the cigarettes that we're varying, do we see? Because when you plot the total number of puffs that are earned on the y-axis as a function of the overall response requirements, you get this cool kind of bending curve, a demand curve it's called, and there are a bunch of ways that we can quantify the characteristics of that curve, and then we can compare them across the 2 cigarettes to see, do people smoke one more than the other when it's essentially free, so it's like 1 puff? How quickly does it take till responding drops off across the 2 types of cigarettes? And at what price does responding start to change dramatically, go from elastic to inelastic, all that stuff that Derek Reed talked about.
And in this case, price just means the number of plunger actuations, right?
Yeah, exactly.
Nice.
And there's some researchers that play around with this idea in more of like a survey format, and they play around with the actual cost of cigarettes. Mm-hmm. And then but there are a bunch of ways, that you can change the price when you're studying these things.
This is a very old reference. I'm not sure how many people in the audience might get, but there used to be an advertisement for Camel cigarettes. It said something to the effect of like, "I'd walk a mile to smoke a Camel."
Yeah, that's it. They're trying to increase the.
So you'll be able to tell how much ergs of energy someone can put out. How bad, basically what you're asking is how bad do you want it, right?
Yeah, exactly. Yeah.
That's what I love this research, because it just really cuts to the core of some of these just fundamental not human, because these things are obviously displayed across organisms, but just fundamental behavioral questions of choice. I think that's one of the things I find so interesting about this.
Yeah. And demand, I think, is also really cool for applied scenarios, because what you can do too is I can plot, say, consumption of M&Ms or something, right? As I increase response requirements through like discrete trial training or something. I can also plot consumption of another reinforcer that may substitute, so it's functionally equivalent or is unrelated to M&Ms, or maybe they're complements, like chips and guacamole, right? They always go together. And so you also see how people will change their access to other reinforcers as I change the response requirements on one. So you get these really cool, it's a way to assess really cool interactions between reinforcers too, which is, if you look at in-home ABA program with kids with ASD, there's all sorts of stuff going on, all sorts of interactions. So yeah, it's cool stuff.
Yeah. The sticker and sticker book, or, taking it out of the realm of service delivery for kids on the spectrum, how many people you see have a few drinks at the bar. Next thing you know, they're trying to bum a cigarette off someone, but otherwise they don't smoke. And, so, I mean, I've only observed that, of course. But anyway, so many cool questions you can examine looking at that. So, so what I want to do, we're kind of already transitioning into the whole realm of drugs and behavior, or behavioral pharmacology, perhaps more precisely stated. And one of the articles that you sent me in advance is Dew's 1955. So tell me a little bit about this as more of a primer, if you will. So tell me about why you shared this paper with me and what's noteworthy about it in terms of this topic.
Sure. Yeah. Great question. So, around the 1950s or so was when behavioral pharmacology was becoming like a thing. And behavioral pharmacology essentially looks at the interaction between pharmacological agents like drugs, or food, I guess, and things. You can think about it in that way too. But pharmacology and then operant schedules of reinforcement and respondent conditioning. So what happens when you smash these two things together? And what I love about this Dew's 1955 paper is figure 4, really. So when I was growing up, I always thought of drugs as, they're stimulants, or they're depressants, or they're psychoactive or something, but it all seemed very biological. Like you consume or you ingest some molecule, it enters your body, it does its thing, it interacts with your biological tissue and behavior changes as a result. But what I love about figure 4 is that it shows how biology and reinforcement schedules interact in really cool ways. And so for the people in the audience, essentially what figure 4 is, on the x-axis, there are 6 different points that show the approximate dose of pentobarbital, which is just a short-acting barbiturate, and it's often used to help with sleep and anxiety. But on the far left of the x-axis is saline. So what happens if we do everything to the organism except actually inject them with the drug? So we just do everything but inject them with a saline solutions like water and some salt and stuff like that. And then the other 5 points on the x-axis are increasing doses of the drug. And then the y-axis is rate of responding after the drug compared to rate of responding before the drug if I haven't done anything. And so that's kind of the x and y axis. And then in the plot itself, there are 2 different data paths. One is closed circles, and it shows responding on an FR50 schedule of reinforcement for access to grain or food, probably most likely grain. And then there's an open circle data path that shows responding on a 15-minute fixed interval schedule. And so on the far left, where it's saline, is kind of the animal's rate of responding if I do everything, inject the saline, compared to if I just let them hang out in the cage and respond on these things. And then as you increase the dose, so as I move along the x-axis left to right, you can see with like the FR50, initially the pentobarbital actually increases responding, which is different than a depressant, right? You're seeing more behavior than you might or than you see without the saline. But if you inject enough drug, then responding comes down. And as with all things, if we consume enough of it, it's going to kill us. So sure. Enough of anything, you'll stop responding. So you kind of see this really cool curve. Then if you look at the 15-minute fixed interval schedule, you see kind of a similar pattern. At lower doses, it seems to be increasing responding, but at higher doses, it drops below responding for the saline. So that kind of suggests that based on the dose of the drug, rate of responding may be higher or lower than baseline, which is kind of fascinating in and of itself. But what really sold me is if you look at like pentobarbital, 1 milligram, exact same dose of a drug. But if I'm responding on an FR 50-second schedule, it's way above the saline, suggesting that it's increasing rates of responding. But if I'm responding on a 15-minute fixed interval, it's way below. It's almost near zero. And so what that shows is this really interesting interaction where the rate of responding will increase or decrease above a baseline level depending on the schedule of reinforcement. And I remember just seeing this figure and being absolutely blown away, like, oh, drugs interact with operant schedules in this way. Like, this is amazing. So that's really why I love this article. It just very cleanly and simply highlights the interaction between pharmacology and operant schedules and kind of what behavioral pharmacology is all about, trying to understand what's going on here.
Nice. And I'll post a picture of that as well so people can kind of follow along. I think you did a good job kind of describing as well as possible in an audio only format, but we'll have some visual supports to go along with this. So cool. Yeah. What are there some, so you have this kind of environment behavior relationship that you just described as, kind of like the aha moment for, at least for, as it relates to your history with this stuff.
Yeah.
Are there other noteworthy kind of findings in the behavioral pharm world that would be important or interesting for the listeners to know about?
Yeah. And so Mark Branch has a paper, 2006 in JAB, that talks about how research in behavioral pharmacology informs behavioral science. So I would definitely recommend people check out that. I think one thing that you had mentioned when we were chatting back and forth is the anti-punishment effect,
yes.
Which is just really, really cool stuff. And for listeners that are unfamiliar, essentially what you do is you can take an animal in a control condition and you maintain lever pressing on some schedule of reinforcement, say like a variable interval 60-second schedule or something. And once responding is stable, you then introduce some kind of punishment procedure like shock for FR30. And so when you do this, you see rates of behavior reduce. That's a basic punishment procedure, which makes sense. Then you take a drug, say like pentobarbital, and you inject the organism before they go through the same procedure, right? So you get responding maintained on the VI60. You then drop them into this component with the punishment procedure from before that would reduce responding. But with the drug on board, responding actually increases, which is wild. So they're still contacting the shock on this FR30, still contacting grain on the VI60. Everything's the exact same except pentobarbital is on board. And you can see an increase in responding rather than a reduction. And so some of the early researchers called this the anti-punishment effect. Because it suggests that, depending on what drugs or things are in our system, stimuli that used to be punishers are not anymore. And similarly, sometimes some things that were reinforcers before may not be as reinforcing. Or one of the classic argument, I suppose, or curiosity about like cannabis or marijuana is that it's reinforcing not because of the state in and of itself, but perhaps because it makes everything else really interesting. So we know that with drugs on board, the function of a stimulus can vary widely.
Oh, I never thought about it in that context. I always thought about it in the context in which Chris Newland described it to us as grad students, where basically because I think this is also observed in alcohol, and basically the things that would be aversive enough for us to think twice about engaging a particular behavior get obliterated when under the influence, and so that's why people like say stupid things or maybe get in fights and whatnot, or maybe text people or post things on social media when they've when they've had a few pops, whereas the potential aversives of that might suppress that responding otherwise.
Yeah. I think that fits pretty well in that in explaining those behaviors. Yeah, when you have drugs on board, responding isn't as sensitive or does different things. Yeah.
Have you ever been part of a team composed of capable, accomplished members that underachieved or failed to launch an initiative successfully? Do you work with teams where members burn out, get in conflict, misbehave, or act in ways that contradict the purpose of the group? Are you currently working with other people towards a common goal and aiming to ensure that every member is empowered for maximum contribution and long-term sustainable engagement? Then consider attending the OBM 2.0, the Pro-Social Teaming Model workshop, which will be taught by Drs. Darnell Littall and Tom Sabo. This workshop is being put on by my friends at Connections Behavior Planning and Intervention. It's being held at Green River Community College in Auburn, Washington on January 18th and 19th, 2020. Attendees will learn the pro-social model, which is an evidence-based practice to promote employee engagement, cooperation, high-level performance, and complex organizational problem solving. The pro-social approach incorporates findings from Nobel Prize-winning research conducted by Elinor Ostrom, with corresponding findings from research in evolutionary science, behavior analysis, ACT, and OBM. Participants will practice core skills and then implement them in a series of challenging role plays that simulate real-life organizational behavioral crises. This workshop will walk attendees through the entire process of creating sustainable team-based outcomes through expert instruction and experiential learning. The workshop itself will provide 16 CEUs, and there's a remote follow-up option that can extend this to 22 CEUs. Space is limited for this event, and the prices go up as we get closer to the dates, so you're going to want to register for OBM 2.0 straight away. And to help defray costs, the folks at Connections have offered listeners a discount. So for more information, check out connections-behavior.com/events, and be sure to use the code podcast25.
That's cool.
I know we're kind of doing a little lit review here, and one other thing I wanted to throw in is another paper that you shared with me about, and I think you called it the party line on drug use from a behavior analysis perspective, and that's Heyman 2013. And I think if I recall I don't have the paper open here on my computer, but I believe the title was something along the choice model of drug taking. Again, this harkens back to some other themes that we've discussed already. So what's noteworthy about this? And I think it's more of a summary of the existing literature, right?
Yeah, and he has a whole book called Addiction Disorder of Choice or something like that. And this paper in 2013 was a kind of a review of that book, as well as some data, I believe, to support that idea. And so the notion of addiction as choice is essentially that continued use of a substance of abuse is a function of the reinforcer value of the drug itself relative to the absence of reinforcement for alternative behaviors that might be incompatible or compete with it. So rather than thinking about substance abuse and challenges with that as a biological disease or disorder, it's more thinking about it in this behavioral economic sense. Mm-hmm. So it's
like so-and-so has an quote-unquote addictive personality. It's more about what are the things in the environment that they have available to them and that are perhaps alternatives to drug taking or other sorts of things.
Yeah, exactly.
Could be eating fast food or whatever.
Yeah. Oh, yeah. There's even a whole literature on I'm going to botch the name for it, but it's essentially non-substance use addictions or behavioral addictions, like gambling.
Sure.
Makes sense when I, take a line of cocaine, that's doing some things, and it's
direct acting for sure.
Yeah. And I can see it. But with gambling, what is a reinforcer? And Dixon's done some cool work on trying to figure that stuff out. But what's surprising is that across addictive behaviors or behavioral patterns that get this label of addiction, that this choice model seems to work. So what we try to do then is load up reinforcers or incentives on an alternative behavior to see if we can how much we need to add to get people to switch from drug use to alternative healthy behaviors, or maybe just abstinence.
Sure. Well, this is a perfect segue because I wanted to talk about some of the, or at least introduce the contingency management literature, of which there's quite a bit of it. So I don't want to put the inappropriate amount of pressure on you to cover it in its entirety. That's probably an episode or many episodes unto itself, but I think it's worthwhile kind of describing what this is for the listeners who may be unfamiliar with it. And I know, like, a lot of this stuff, it goes back 20, 25 years. I remember reading about it as an undergraduate, which was in all honesty, about that length of time ago. And, so tell us, talk about some of the interventions that are being done from a contingency management framework.
Sure. Yeah. So a lot of it involves, and they're usually called incentives because a reinforcer assessment is never really done. So essentially it's taking incentives, often in the form of money or gift cards, or sometimes in like treatment facilities, they'll earn like tokens essentially to get access to a closet of things, like a TV or things like that. So the researchers or the clinicians will take these incentives and they make access to it contingent on providing some kind of verified, biologically verified sample suggesting they're abstinent, that they have not used. And that's essentially the main idea, try to get people add incentives or reinforcers for not using. And then a lot of times researchers will also use an escalating schedule. So for every consecutive sample that's clean, the amount that people earned will increase or escalate over time. And if they come up positive or they miss a sample, they'll reset back down to the base rate. And it turns out when you do stuff like that, you can get really big changes in behavior and rates of substance use, even with as little as a few dollars a day. I think I'm pretty sure it was Jesse Dallery and Allison Curdy for walking. So pro health behavior generally, this is also used in Java, but it was like $1 a day or something like that. And they got people to increase their overall physical activity with, it was really, really impressive stuff. So with a little bit of incentive on this alternative, you can get people to switch over.
Do you know what the long-term outcomes for those sorts of things? Like, I'm just go right to like, okay, what's the generalization? What's the faded? I think the actual interventions themselves are fascinating, and I think from just a basic behavioral principles standpoint, it makes sense. And obviously, when you can get people doing more productive things, or at least avoiding unproductive things or things that are barriers to living a more successful life, that's a good thing. And so my curiosity lies, and I'm nowhere near up to speed on what this looks like in the literature, but how do you fade these things? Do you fade these things?
Yeah.
Where do you go once you get the behavior change? Do you maintain this intervention that could be costly or cumbersome or what have you?
Yeah, great question. And I think every contingency management talk I've been at, this has come up. So I'm sure a common question that people in the audience are probably thinking of. But yeah, it's a challenge. The rates of relapse, I can't remember numbers offhand, but contingency management very generally shows much better rates of abstinence at the end of intervention compared to all other pharmacological treatments and things like that. And then rates of relapse are very similar to other treatment approaches. So relapse is a thing. I don't think anybody's really figured out how to fade it well. And most of that is likely because contingency management is still very, very much research-centric intervention. It doesn't seem like it's caught on as much out in the wild, so to speak.
Okay, so it's not being practiced at like community mental health centers or other types of addiction centers that you see out and about.
Yeah. So a lot of researchers will get these like 2-year grants where they're testing a 12-week program, and so they haven't had to think about that as much. Except Nancy Petrie was getting some stuff going at the Veterans Affairs. I think they might have worked it into their standard of care. But I will say, because this often comes up, what happens when you take away the incentives? Rates of relapse for substance abuse are an issue with all interventions. And so it's more of a question for the field, I think, as a whole, rather than specific to contingency management. But it's a real challenge. Yeah. That's I guess one of the other areas of basic EAB that people might be, if they're curious, like hot topics, relapse and resurgence and renewal and reinstatement, all those things are kind of hot topics right now. And I think JAB is going to have a special issue on relapse coming out next year, so audience could just wait for that.
Very cool. Yeah, I have a friend of mine whose son actually went to treatment for addiction to painkillers, and when he was being discharged, it just said plan on relapse.
Yeah, it's definitely the norm.
Let's plan and prepare for it, because the likelihood of it happening is very high, and there are a whole host of things you don't want to do when that happens, and there's some like continue to go down the spiral, so it's like understand, accept that the relapse is very likely to occur, and then have a plan to get back into treatment, or have some sort of intervention in place for when that occurs, so you minimize the potential damage that could do.
Oh yeah. I mean, and I'm going to kind of make up this number on the spot, but I know it's in the rough ballpark, but it's something like 10 or 15% of individuals that'll complete any intervention program will maintain their abstinence for 1 and 2 year follow-up. It's really low. It's a big challenge in substance abuse interventions generally. The other thing I think that's really cool about contingency management, which I didn't appreciate until I got more into it, because I was used to 10, 20, 30 hours a week in-home ABA hours. I have an RBT that's running and maintaining contingencies in the home, and then shifting over to pro health behaviors like physical activity, diet, substance use. You maybe get an hour a week with an individual for like 15 minutes. And so even just figuring out how to objectively measure behavior is hard. To try to even think about any kind of functional assessment raises a lot of challenges that really haven't been figured out yet. And the biological verification of drug abstinence is also really expensive, to be drawing blood or getting urine samples and stuff. So people that are interested, there's a lot of opportunity for some smart people to come help try to solve some really important problems. And I think I saw a stat like 1 in 5 people or something like that will contact some substance abuse challenges in their life, whether it's themselves or someone they're related to. So a lot of people experience it.
For sure.
Yeah.
Well, that brings me to another topic I wanted to get into, and it's probably something that, well, you mentioned it earlier, and that's this whole idea of the use of psychedelic interventions for treating, well, it seems just about anything. So like if you listen to certain podcasts, it seems like taking mushrooms is good for what ails you, and I'm kind of joking around, but at least there's been some clinical interventions that show very, very promising results. For I think the article you shared with me was about quitting cigarettes, but I've seen some work done on like treatment-resistant depression and PTSD. I think there's some work going on in anorexia and all sorts of other things that traditional, quote unquote, traditional intervention methods have struggled with. And I know Johns Hopkins is like ground zero for that research, right?
Yeah. Oh, yeah. We just got a huge grant to enter the center. I should know this. Center for Consciousness and Psychedelic Research or something like that. But
is that the one that Tim Ferriss was involved in?
Yeah. He was out there interacting, with the bigwigs. I'm a lowly postdoc playing with secondary analyses of data. So it was the talk he was on there. And then Matt Johnson is the researcher I primarily work with, and so he's done a lot of stuff on NPR and 60 Minutes and stuff lately. It's a hot topic for sure.
Yeah. So for those who may be unfamiliar with it, or just kind of casually familiar with it, I think anytime you bring up quote unquote magic mushrooms, it kind of generates some snickers and things or laughs or what have you, and people might be interested in telling stories of misspent youth or what have you, but we'll put that aside for a minute. And all seriousness, so what are take us through some of the applications that it's been used with. What are some of the outcomes that we're seeing, and where we need to go to further understand what's going on here?
Yeah, all great questions. And I think you hit a lot of the big ones thus far. So cigarette smoking, treatment-resistant depression in individuals with, I believe it was end-stage cancer or some kind of terminal diagnosis. There was a study done with individuals that had a history of meditation, I think, as well. And then King's College London has also done a lot of stuff, although I believe they use slightly lower doses of psilocybin, of the active component in magic mushrooms than we do. And all the results are really interesting. The article I sent you is wild. So it's Johnson and colleagues, 2014. These individuals had approximately 30 years of smoking, about 20 cigarettes per day. And so if you stop and think about it, that's a little over 200,000 pairings of that hand-to-mouth cigarette smoking with all the reinforcers that come along with it.
And all the contextual stuff like reading the paper, having coffee,
coffee's a big one. Yeah. So all this stuff that's going on, right? And then you can look at the graph. I don't remember which figure it is, but 15 participants, one psychedelic session, and 12 of the 15 stopped completely. And that, so an 80% success rate. That's higher than, contingency management at its best 9-12-week program. We were like 50 or 60% abstinent rates. So one psychedelic experience and these people stopped. And so from an opera perspective, like, I don't know how you explain that. So I saw that and I was hooked. I was like, I got to figure this out. This is fascinating. And so it's those kinds of results that I think are catching people's attention. The dramatic shift after one, maybe a few psychedelic guided trips, the large changes in the proportion of participants that respond to it compared to other interventions. They have a lot of people looking at it, at what's going on.
What does the actual intervention look like?
Sure.
Yeah, let's talk about so let's say I have, PTSD or one of these other conditions that and I'm fortunate enough to be involved in this. This stuff obviously is not standard of care by a long shot, right? Yeah. So let's say I get hooked up with Johns Hopkins or some other research facility. Walk me through it from a patient perspective. Like what am I going to be doing? Yeah.
And every study varies a little bit differently, but the general components are that you would be screened, and there's a pretty heavy screening process because there are a lot of risks to taking a hallucinogen. So a pretty rigorous screening process to make sure that the individuals come through are as healthy as possible, and ideally it's just the one target behavior that they're wanting to change. They then go through 4 to 6 week, again, kind of varies depending on the study, but some kind of preparatory period where they're coming in, they're meeting the staff, they're checking out the environment, becoming familiar with everything. A lot of baseline assessments and stuff are done in that period. They would then prep, and then they would come into the lab the morning of their trip, and they essentially get this pill. They hang out in this room with the therapist guides that walk them through this, and they've been doing this stuff for 15, 20 years, so they're great at it. And person goes on their trip 4-6 hours, make sure everyone's okay, send them home, and then they come back the next day, and there's an integration component. And this is
hang on. I'm just sorry to do this, but so they come in, they take the pill, and then where do they hang out? And what do they do? What activities are available? Yeah. I'm sorry. I'm just fascinated by this.
What's going on?
Yeah, I want to picture it in my mind, and right now it's just like this, kind of. So just set the scene for me, if you could.
Yeah, sure. And I will say on the Hopkins Center for Psychedelic Research and Consciousness or whatever, they have photos and videos and stuff if people want to check it out.
Okay.
It's really cool stuff. But yeah, so they come in. There's a couch that they can lay on or sit on, whatever they're into there. But they lay down on this couch, they put on eye shades, they listen to a music list. And
what is the music?
Yeah.
Please tell me Pink Floyd.
And I always think I should write this stuff down. I actually don't know offhand. I believe it's a list of classical music.
Okay.
But I'm pretty sure it's on the website, but it's the same one.
Okay. Okay. So that's standardized. So it's,
it's okay to pick Pink Floyd or whatever and just coast off into the.
Sorry, I couldn't resist. That was low hanging fruit.
Oh yeah. So they come in, eye shades, earphones,
And
That's it.
and so the guides are there just to do they engage them in any process, or is it just basically kind of going off the patient's lead? So if the patient has questions or they want to quote unquote talk, I don't know why I said quote unquote. If they want to talk, they talk. But is there any scripted type of interaction or anything like that, or is it just kind of going off the lead of the patient itself?
Yeah, just kind of go off what happens. And I've never run any of these sessions, so I'm only speaking based on what I've heard. But from what it sounds like, they let the individual do their thing. If they start to have like a bad trip or something, they might help them out, redirect it, guide it back. If the individual has to like go to the bathroom or something, or needs water or something to eat, they'll manage that. Cause it's 4 to 6 hours.
Sure.
But generally the goal is to hang back and just let it unfold.
I see. And is the nature of those interactions during the trip itself important from a clinical perspective, or is it the actual, pharmacological insult, if you will?
Yeah, that's a good question. So the one, and again, every study's done a little bit differently, but the one component, in addition to the drug itself, or consumption of psilocybin, is the next day afterward, they'll come back to the lab and they have what's referred to as an integration session. So they come back in and they talk with a licensed psychologist, a counselor, or somebody that has, or a psychiatrist that has some kind of training in talk therapy, if you will, or verbal communication. And they talk about what it was the individual experienced and how that might relate to whatever they're in there for, smoking or depression or whatnot. And it seems to be, and so that's, I guess, one thing that a lot of the members of the Psychedelic-assisted Center will reiterate is that it's not necessarily just popping a pill and tripping for 4 hours that does it. There's some kind of combination of that plus talking with somebody about what you experienced, how it relates to the behavior you're trying to change. That seems to be the two main components where success is observed.
I see.
And some studies will throw in like cognitive behavioral therapy in between dosing sessions, or they'll add in weekly text things and what have you. So some studies will add in other components, but the big ones that seem to be consistent are the trip itself, the integration session, and then there are some characteristics of the trip that seem to also pop up pretty regularly.
Like what?
So one that's really interesting, I never thought I'd be saying this as a behavior analyst, but if an individual, it's called a mystical experience. Mm-hmm. So if an individual has some kind of mystical experience during their trip where they report contacting some kind of thing that's larger than themselves, that also individuals that have that experience tend to have better outcomes as well. But again, going back to how to explain that, I have no idea.
I don't know. I mean, maybe this is a super stretch, but perhaps from an ACT perspective, if it broad changes your values and your values directed behavior is different as a result of that. And I don't know. I'm literally just throwing darts in the dark, though.
Okay.
So.
No, that makes sense. I mean, I think if you look just like pre-post, stimulus relation, the function of stimuli in the environment that we're evoking behavior X are changing. Whether that's value perspective, stimulus control perspective. Maybe people are attending to those things anymore. I have no idea.
Yeah.
Trying to assess that is what we're trying to do. And so that's what a lot of the money that is going into the grant now is just try to figure out, do we see similar things across a few more behavioral paths? And then they've also tied in some neural imaging, like what is the brain even doing or how is it changing pre-post? And then a bunch of other smart people are, playing around with assessments pre-post to try to figure out what is going on exactly.
Wow. And just utterly fascinating. I would love to know more about the content of that post-trip kind of integration stuff, because if that's a key variable, it'd be interesting to see, what are the important aspects of that are contributing to a successful outcome?
Yeah, definitely. And the other thing I guess that's important to note is that the demographic of individuals that have been brought into the study has been pretty restricted to middle-aged, often white males they have time to take days off to go on the psychedelic trip, so they're probably higher SES. Again, very carefully screened for health patterns and or healthy behavior and background. So it's exciting for the center to have the money to expand out and I think broaden and try to figure out what's going on with more diverse populations and things. And the other really tricky thing about a lot of randomized controlled trials and drug stuff generally is you offer some kind of placebo or control pill. It's hard to do that with psychedelics. When you're tripping or not. Yeah.
Are you ready to make the leap from pen and paper into the digital world? Do you spend hours taking notes, tracking data, figuring out schedules, and even worse, dealing with insurance billing? Or are you frustrated by your current system? Well, I recommend you check out Go Lotus. Go Lotus was created by a product development expert who spent years building systems for Apple and Microsoft before her child was diagnosed with autism and everything changed. She created Go Lotus with one mission in mind: to create a platform that could help therapists better treat their kiddos by providing a tool that allows them to focus on the actual work, not the paperwork. Go Lotus is an intuitive, easy to use, and dare I say, beautiful system. It handles every aspect of practice management, from data tracking and automatic SOAP notes to scheduling and billing. They even offer a white glove in-house billing service if you want billing fully managed outside your clinic. It's so simple your entire team can be up and running in less than an hour. For more information, go to golotus.com/register for a free demo. And if you do sign up, tell them I sent you, or just use the coupon MATT2019 and you'll get 25% off the first 3 months. They're so confident that you will love their system that they allow you to cancel at any time. There's no risk and no commitment required. So again, if you want more info, head on over to golotus.com/register. Totally. I could just ask questions endlessly on this, so I think I'm going to just ask you if there's anything else that you'd like to mention about this line of work, and then move on, because otherwise I'll just sit here and keep asking questions. And we'll be in some rabbit hole, an hour from now, and but I got some other topics I want to get to as well. So
yeah, sure. No, I think that's about it. I would, if people are interested, I would encourage them to check out the center website. They have all the publications on there to see what's been done and what's coming up in the future. Okay. Yeah. Well,
I feel good that there's a behavior analyst that's part of this work. So I think getting that perspective in there to help interpret these things is beneficial. So so I appreciate taking some time to kind of outline this very new line of research. So
yeah, no problem.
All right, so let's get to some listener questions. We got a range of listener questions, and when I said we're going to be talking about drugs and behavior, actually, silly me, I didn't outline the context of drugs and behaviors as well as I should, and so I ended up getting a lot of questions about psychotropic drugs, generally for individuals with autism and DD and things like that, in addition to behavioral pharmacology stuff. So we're going to have a kind of a smattering of that here and there, but let's see. So let's just kind of jump into it. So Louisa asks, as a BCBA working at home with kids with autism and other diagnoses who use drugs, how can we as BCBAs help the doctors who are prescribing? I found barriers to be heard by the doctor even if they're offering to collect data on problem behaviors. So I think that's something we all encounter quite a bit, right?
Yeah. Oh, yeah, definitely. And it's a really important question. I don't think there's a great one-size-fits-all answer. I think it was Poling and Lee, and I think there might have been one other author, had the Behavior Analysis and Practice, pretty sure it was Behavior Analysis and Practice, article on collaborating with physicians But the contingencies are so different that are operating on that MD's behavior. And each one is probably a bit different in terms of each prescribing physician that a BCBA might be interacting with is probably under different constraints. But the general strategy, I guess, that I've found successful is to go in person to talk to the doctor so they can't ignore your emails or phone calls. Mm-hmm. Accompany the client if possible so the MD can bill, because, at the end of the day, just like us, they have billable hour requirements and things like that they have to meet. And the standard doctor visit is 15 minutes or less. So you'd have to come in with questions prepared to fit within that window, and really just starting to get an understanding of what information would be helpful to the doctor and how we can help them out. And through developing kind of that cooperative, collaborative relationship over time, you'll probably start reducing some of those barriers and also start figuring out what exactly would be helpful to the physician. My guess is they don't have a background in behavior analysis, so when we ask them how we can help them, they probably have no clue, because they just haven't even thought about the stuff that we think about.
Yeah, I think also probably avoid any technical jargon as well, so you can speak in a language that everyone can understand. So cool. Let's see. Pranali asks, I've recently seen some clients provide CBD oil. I knew CBD was going to come up in this. So I've recently seen some clients provide CBD oil to their child to reduce problem behaviors. I was wondering if there's any research in this area, particularly with behavior reduction, and how we can isolate that this is the independent variable that is directly affecting the dependent variable. What are your thoughts on CBD?
Yeah, so
another good for what ails, just right. Or at least if you listen to popular culture, right? You can't get away from this topic.
My favorite is the when they try to get you to give it to your pets. Like, I don't know, it just seems hard to
my vet recommended that, by the way.
Did he? Yeah. So did ours for our older dog with arthritis. We tried it. I didn't see any difference.
Yeah.
But the research on CBD generally is very minimal, just maybe starting to come out. And the other thing that's really interesting to think about is a lot of the cannabis and CBD industries are unregulated. So even if we had really good research on CBD at specific dosing levels and things like that, it's unclear what exactly is in a lot of those products.
So you could be buying something and it may or may not have, it may have varying quantities of the active ingredient in it, basically.
Yeah, exactly. Because, with like the FDA for, I don't know, water or soda or something like that, they have specific windows that they have to fill when they're making that product. It has to shake out within a certain window. Low variability in product development design. There isn't that for CBD right now. So that makes it challenging. But I think if a parent was really playing around with this, and this I guess kind of goes for a lot of drugs to understand how it's interacting with our programs, you'd think about it like any other independent variable. You try to precisely define the implementation procedures of the CBD administration, collect data on procedural fidelity. So what dose amount are they giving and when is it being administered each day? You define the behaviors that should be impacted or that they're expecting it to be influenced by CBD. Collect data over time, a few weeks, and then see if you can get the parents to do a reversal to shake it out.
Yeah, so some of the just kind of standard things we would do to do some sort of analysis of any other type of intervention. Yeah. I think the trick would be holding other things constant, especially in an applied environment. But the extent to which you could do that would be certainly helpful. So
and I don't know the exact time that it takes so all drugs take a certain amount of time till they stabilize in the bloodstream and you see the drug effect. I'm not sure. My guess is CBD is pretty quick, so I can't imagine that you could probably run it over the course of a week. CBD on, week CBD off, week CBD on. You could probably hammer it out.
All right, so maybe we can have a study with an N of 2 with our dogs as well, and because I bought the $39 bag of CBD treats myself, and
Did you notice a difference?
No, but I mean,
Yeah.
to be honest, I didn't really. I probably didn't provide it on a consistent schedule either. Being a bad dog parent, but you know. This, and it's funny because this was prescribed for "quote unquote" anxiety. I'm using air quotes. So anyway, that's another rabbit hole. But all right, so let's move on to Victoria. Victoria's bringing up the psychedelic issue again, and I'm happy to oblige. All right, what role could a behavior analyst play on a team that is researching the benefits of psychedelic therapy? What could we bring to the table with our skills and knowledge of behavior that other professions may not be able to offer?
Yeah, that's a great question. So behavior analysts are really good at identifying the antecedent stimuli that evoke specific responses that then co-vary with consequent events. And kind of like we talked to a little bit earlier, trying to capture what functional changes are occurring in stimulus relations and response-stimulus relations pre-post. I think that's a skill set that we have. If we're thinking about like the integration sessions or some of that other stuff, because the psychedelic is usually laid on with some other therapy as well. If people have a background in ACT, like you had brought up, or other kind of verbal talk therapies and things, that's another way they could sneak into a team or something like that. The other realm, which is an area that I've really enjoyed, is to try to figure out what participants are experiencing, though, after their psychedelic session. They'll give us a verbal narrative of what happened, as best I can remember, I'm sure. And one of the areas I'm playing around with is trying to analyze that verbal behavior to see if there are patterns or things that might predict whether an individual will change their behavior or not. And so that would be another domain. I think people, we're good at verbal behavior and understanding when, how, why it occurs, how it relates to the environment. And so bringing that into the analysis would be a huge benefit, because a lot of the current analyses on psychedelic session narratives take more of a classic linguistic approach. So that would be another realm.
Cool.
Yeah.
And she wants to know how to get involved in conducting research with psychedelics, especially if she's not currently enrolled at a university, and et cetera, et cetera. So if there, that might be a tough question to answer given how limited the research is being, the limited sites it with, maybe like move to Baltimore might be, right?
Yeah. Check our job boards and see if they're hiring research assistants. There's also, so that definitely is one aspect. There's also the MAPS, so the Multidisciplinary Association for Psychedelic Studies. And they have a list of current research projects and how people can get involved and things like that. But I mean, if someone's really, I'll also say, I guess, if there are people out there working on their PhD that are interested in this, the Center for Psychedelic and Consciousness Research at Hopkins, they are going to have 5 postdoc opportunities beginning, I think, next year or something, to try to grow that out. But yeah, you got to find someone that's doing this in a legal way too. I would definitely stress that.
Oh, yes. That kind of went without saying, but probably should be said regardless. Yeah. I'm glad you mentioned that. So,
that MAPS Association probably highlights some ideas of people to contact, and good luck. They'll have to come in with some humility and ready to learn a lot, and to see where the trip takes them, I guess. Yeah.
All right, that's good advice. And let's see. She also asks, is Dr. Cox familiar with Risperdal and its use in children with autism? So can he please explain the mechanisms of action and why he thinks it's so often prescribed? Many of my clients take this medication. From what I can tell, has some pretty gnarly side effects. And on top of that, doesn't seem to work or help most of the time. So why are I'm summarizing here, Victoria, I'm sorry. But just so why is it still being prescribed? I have seen it actually work sometimes pretty well. And I've also seen it not work at all too. But I remember when it came out, it was being used off-label because it's an antipsychotic, and at its core, that's how I think was it Johnson & Johnson developed it, I think, if I'm not mistaken. Yeah. Again, this is going back 20 years or so, but I remember when it was first started becoming prescribed for that, and it was, for many of the individuals that I was around who had severe repertoires of self-injury, physical aggression, etc. For some of those individuals, it was very, very helpful. And then obviously for others, it wasn't. And certainly there were others that had side effects from it, whether it was, like some of the ones that she mentioned, or, even gynecomastia and other sorts of really not cool stuff. So, so what are your thoughts, if any, on Risperdal or Risperidone or whatever you want to call it?
Yeah. So I'd say my experiences are similar to yours in that I've seen some individuals that it really helps with, some that it doesn't. From my understanding, the biological mechanisms of action aren't fully understood, but it is often used to help treat schizophrenia, bipolar, OCD. And then actually in 2012 or 2013, the National Institute of Health and Care Excellence over in the UK, they suggested in a publication that it could be used to help managing challenging behavior for young people with autism spectrum disorders. So that's probably where a little bit of that kick up popped up in the early 10s. Is that what we call it? Because that information probably trickled across the pond to us over here. Mechanism actions are unknown. Some kids it's worked with, some it hasn't. I think similar to any other pharmacological compound or drug, it's going to take collaboration and cooperation skills with parents, physicians, other people that are on the intervention team, teachers, OTs, SLPs, anybody that's impacted by the challenging behavior, and everyone's going to have to get on the same field with how they're going to think about and assess any intervention really, but drugs included, and its impact on challenging behavior.
I see. Anne writes in, have you read the book called Dope Sick by Beth Macy? Are you familiar with it?
I've heard of it, but I haven't read it, yeah.
And she's reading it as part of a book club, and some of the things that she's again, Anne, I'm kind of paraphrasing here, but she finds intriguing about this, but also appalling, is the interaction of drug representatives and doctors. What in being a researcher in this world, do you come into contact with that aspect of it? Are drug reps coming in and meeting with the physicians at Hopkins, and what's your general take on that piece of it?
Yeah, that's a good question. So we have some in the behavioral pharmacology research unit, and we have one gentleman in particular who manages all the interactions between any kind of industry, agency, or organization that wants to conduct research with us. So I've never interacted with any of the big pharma or any reps or anything like that. I think they channel it through there, and there are some pretty strict guidelines, I'm sure, on the quality and nature of the science to test any kind of drug that they might be interested in us developing. But as outlined in that book, it's common for, every doctor's office you go into and they have, the little pens with the drugs on them and stuff. Yeah, that had to come from somewhere, and lunch was probably given. I've heard stories of people paying doctors to go to conferences and things like that. So big pharma is a thing. They have a lot of cash and they want to make more money. So yeah, it's there.
Yeah. I think, I remember when I worked at a residential school, we had we didn't have a psychiatrist on staff, but we had one that visited like every week or every other week. And every once in a while, actually it was the Johnson & Johnson rep. It was the Risperdal guy would come and he would like cater a lunch and do a presentation. Yeah, he had to pair it with some sort of educational, event. Because I think at the time they were cracking down on just like the blatant kind of, I don't know if they call it quid pro quo, but So I've seen that firsthand. I've also, I just know some people, some just acquaintances in general who are reps for various companies for various types of medications and things along those lines. So it's a messy business in many respects. And and on the one hand, you have big pharma. People like to kind of vilify big pharma, and in many cases that's certainly appropriate. And then at the same time, producing these drugs is expensive beyond, most people's wildest imagination, and so that money has to come from somewhere too. And it's just I don't know if anyone's figured out the most ethical way to conduct the research, develop the products, market it in a way that works for everyone. So it's definitely a conundrum.
Definitely. And then thinking also the number of drugs that failed through development too. So the one in however many hundreds or thousand actually gets all the way up to make them money. So there's a lot of cash going into failed attempts.
Yep. And I don't want to sound like a shill for the industry or anything like that, but it is something, from what I understand, it's a profoundly expensive endeavor. So anyway, yet another topic we can go on and on for a while, but I think what I'd like to do is perhaps we're coming up on the end of our time here. So what I'd like to do is always to kind of close the show here, and by asking the following, what is your advice, David, for a newly minted BCBA?
Yeah, so I have, I guess, kind of two parts to it. The first advice that I would have would be to find 15 to 20 minutes every day to read a journal article. I think life only gets busier once we get out of our programs and we kind of get out into the wild and we're providing services and contingency that are competing for your time and attention. But with fluency, if you even take 2 weeks off a year, you could be reading like 350 journal articles. And in JABA, JAB, and behavioral analysis and practice combined, it was like 215 articles in 2018. So you'd be current on the literature, which is nice. And so then the second part of that advice is with those additional articles, once you establish this pattern of reading articles daily, to read broadly, kind of get outside of behavior analysis, read about all the cool areas of science that are going on in the universe. There's a lot of really smart people doing a lot of really good science and asking cool questions. And if someone is pushing around behavior out there in the wild, I want to know about it, because that's what we do as behavior analysts. So it'd be read daily, 15, 20 minutes a day. Doesn't have to be crazy. Use that to increase the depth of your own knowledge in behavior analysis, obviously, but then especially to broaden your understanding of human behavior to other disciplines.
Excellent. And do you have any recommendations for areas outside of behavior analysis for folks to pay attention to?
Yeah, this is going to show my own interests 100%. But economics, I think, is really fascinating. And then also behavioral ecology is a really cool domain housed within biology primarily that focuses on environment, behavior relations as well, just usually with non-humans. And they're doing some stuff that's very similar to what we're doing that would be relevant. Is
there a particular journal within either one of those realms?
Oh, that's a good question.
I'm sorry, I'm here.
Yeah, no worries.
I'll tell you what. Let's just do this. We'll just put it in the show notes. So if you find something and you think of something later, just send me an email, and I'll put that in the show notes are going to be very resource dense for this particular episode, as it should be, because these are important matters, and I really appreciate you coming on the show to talk about them, David. So thanks so much.
Yeah, without a doubt, my pleasure. Thanks for having me on. I appreciate it, Matt.
Thank you for listening to the Behavioral Observations Podcast with Matt Sikoria. You can find Matt's notes on this episode at www.behavioralobservations.com. We also invite you to stay connected with us on Facebook at facebook.com/behavioral observations and on Twitter at Behavior Podcast.